on behalf of Medicine 2. Coming to the case scenario, Mr. M, 65 years old gentleman with prior comorbidity of diabetes mellitus, came with complaints of left-sided headache and drooping of left eyelid for 10 days and fever for 1 week. Coming to the history of presenting illness, he was apparently well before 10 days and then he developed headache, which was insidious in onset and gradual in progression, unilateral, that is left side, and throbbing type, not associated with vomiting, nausea, or redness in the left eye, not aggravated by coughing or bending forward or straining. There was also a history of deviation of mouth to the right side, and he had drooping of left eyelid, which was insidious on onset and not associated with seizure. He also had fever for 1 week, which was low grade and not associated with chills or rigor. So he didn't have any other positive history or neurological history. So coming to the past history, he is a known case of type 2 diabetes mellitus for 25 years on oral hypoglycemic agents. He is also a known hypertension for 15 years on antihypertensive medication. He is also a known case of probable rheumatic heart disease status post mitral valve replacement in 1998, after which he underwent he had this valve dehiscence. For that, he underwent reduced sternotomy and had double valve replacement in 2019. So coming to the examination, when he arrived, he was vitally stable. Coming to the central nervous system examination, higher mental function was normal. Optic nerve, his right eye, this counting fingers at 6 meters was present. Left eye, he was able to count feet only at 1 meter distance. Left eye ptosis is present. Pupil is right more than the left, that is reacting to direct and indirect light reflex. Left side, it's diminished. Extra 3, 4, 6 cranial nerve. Extraocular movements, left eye extraocular movements restricted. Lateral rectus palsy is present. There was no nystagmus. So fifth nerve, there is loss of fine touch present in the V2 segment, that is below the nose in the cheek region and above the mandibular region, and there was absent corneal and conjunctival reflex was also present. And there was element facial palsy on the left side with the absent frowning, and Bell's phenomena was present with the absent nasal furrowing and deviation of mouth to the right side. Other examination wise, there was 9th, 10th and cranial nerve gag reflex was present. 11th and 12th cranial nerve examination was normal, and other motor system and sensory system cerebellar signs were all normal. Other system examination wise, he had valvular click, otherwise it was unremarkable. So coming to the syndrome complex, patient presented with syndrome of multiple cranial nerve palsy involving left, second, third, fifth and sixth, fifth and sixth and seventh cranial nerve. So localization will be orbital apex and left element facial palsy, probably after exit from the stylomastoid foramen. So because he had fever, the differential we considered initially was infection. Because he was a diabetic for 20 years, fungal infection was the one initial thing we thought of: mucormycosis, aspergillus, actinomycosis, and other bacterial infection. Inflammatory, Tolosa-Hunt syndrome and sarcoidosis, neoplasm, acute onset, but if the patient had tumor inside and he had an immediate hemorrhage, that could have also have been this acute presentation. So we thought of neoplasm also. So coming to the investigation wise, initial investigation, HP was 8.6 with the WBC count of 27,600, the neutrophil of 85 and lymphocyte of 2 and monocyte of 13. Platelets of 5,31,000, creatinine, LFT and other investigations were all normal. Because he had localized to orbital apex and left element facial palsy, he went ahead with MRI brain, which showed soft tissue mucosal thickening involved the left maxillary, ethmoid and sphenoid sinuses with fat strand and obliteration of the drainage pathway in the pterygopalatine fossa. And patient also had extension of the infection into the sphenopalatine foramen and into the cavernous sinus. He also had involvement in the nasopharynx, pterygoid, masseter and carotid space, as well as the left parotid and anterior fibers of temporalis muscle. This helps us in localizing, because he had this all sinus involvement as well as the cavernous sinus, orbit as well as the left parotid involvement, which helps us in localizing to the 2, 3, 5, 6 and 7th cranial nerve. So we went ahead and did biopsy. It showed acute invasive granulomatous fungal rhinosinusitis by broad aseptate fungal hyphae resembling mucormycosis, and separately lying fungal ball containing aspergillus mucormycosis in the left maxillary sinus, left middle turbinate and left ethmoid sinus. So our diagnosis is acute rhino-orbital cerebral mucormycosis, the background of uncontrolled diabetes mellitus. So why this topic is because I wanted to talk about the localization regarding the multiple cranial nerve palsy. So I'll be talking about orbital apex disorders, anatomy, cavernous sinus syndrome, orbital apex syndrome, and the localization. So orbital apex disorders involves actually three conditions. One is cavernous sinus syndrome, orbital apex syndrome, and superior orbital fissure syndrome. So coming to the cavernous sinus, so anatomy of the cavernous sinus, it is present above the base of the sphenoid bone. So I'll be focusing mainly on the structures involved and the in the case of involvement of the cavernous sinus. Mainly the structures in the lateral wall of the cavernous sinus are oculomotor in the descending order, oculomotor nerve, trochlear nerve, ophthalmic nerve, and the maxillary nerve. Structures passing through the cavernous sinus are the internal carotid artery with the sympathetic plexus surrounding the carotid artery as well as the obtuse nerve. So if the cavernous sinus is involved in case of mucormycosis or in the thrombosis or infective thrombophlebitis or the neoplasm, all of the structures can be involved based upon the structures compressed in it. So commonly involved is the oculomotor nerve and the obtuse nerve. If the internal carotid artery compression with the sympathetic plexus of nerves are also compressed, they can have Horner syndrome also. So coming to the orbital apex anatomy, this orbital apex consists of superior orbital fissure and the optic canal with its contents. So this is a superior orbital fissure, inferior orbital fissure, and this tendinous ring of zinc containing a part of superior orbital fissure and the optic canal. So the contents commonly present are lacrimal nerve, frontal nerve, trochlear nerve, superior division of the oculomotor nerve, and the nasociliary nerve, and the inferior division of the oculomotor nerve and the obtuse nerve. So this contains third nerve, fourth nerve, fifth nerve, that is mainly first division as well as the obtuse nerve. In the optic canal, it involves the optic nerve as well as the optic artery. So in the case of orbital apex syndrome, it involves the part of the superior orbital fissure as well as the optic canal. So the patient will have third, fourth, fifth, and sixth cranial nerve palsy along with the optic nerve involvement, whereas in the superior orbital fissure, this optic nerve is usually not involved, so they will have other cranial nerve involvement. So coming to the orbital apex syndrome presentation, they will have encompass of three elements. One is the visual loss due to the optic neuropathy. Second one is ophthalmoplegia due to third, fourth, and sixth cranial nerve, and ocular or orbital pain or anesthesia due to involvement of the ophthalmic division of the trigeminal nerve. So etiology wise for the orbital apex disorders for the cavernous sinus, orbital apex syndrome, and the superior orbital fissure syndrome include the traumatic, this craniomaxillofacial fractures, iatrogenic post-surgery patient can have this palsy, neoplastic, they can have metastasis secondary to squamous cell cancer or adenocystic carcinoma or lymphoma, leukemia or nerve sheath tumors. Infections commonly this Aspergillus mucormycosis, bacteria Streptococcus, Staphylococcus actinomycosis, and MTV can also sometimes present. This virus herpes zoster, they will have this trigeminal nerve predominant involved other than the orbital apex per se. So other inflammatory causes include sarcoidosis or pseudotumor or IgG4 disease. Vascular mainly involve the cavernous sinus thrombosis and carotidocavernous fistula, carotido-cavernous aneurysm. The developmental hereditary include dermoid, epidermoid, neurofibromatosis, endocrine, thyroid, ophthalmopathy can be present. So with the history and examination, we'll be able to, it will give us a clue to the etiology for the this orbital apex disorders. Because the patient had fever, infection is most likely. So the commonly in uncontrolled diabetes, Aspergillus mucormycosis, actinomyces are common. And those infections are usually common in immunocompromised individuals like uncontrolled diabetes, solid organ or hematopoietic stem cell transplantation, or the patient is on long-term steroids, that will help us. Whereas in the carotido-cavernous fistula, there is pulsatile proptosis will be present. In the Tolasa syndrome, boring or gnawing pain will be present. IgG4 disease also, they will have proptosis, which is not painful. Sarcoidosis, they will have other organ manifestation, mediastinal lymphadenopathy. With the collective findings, we'll be able to localize to the etiology of the cause for orbital apex disorders. So clinical features will be the third, fourth, sixth nerve palsy associated with the, if it is a orbital apex syndrome, painful ophthalmoplegia with vision loss, they can have reduced or total loss of vision, or they can have vertical or horizontal diplopia, inability to open the eye, proptosis, facial pain, and abnormal head posture. Because they have diplopia or blurring of vision, they have this abnormal head posture. So finally, how to localize these three syndromes? The orbital apex syndrome is otherwise called as Jacquot syndrome. The cranial nerve commonly involved is 2, 3, 4, And the V1, that is first division of maxillary plus or minus second division of maxillary can be involved. Superior orbital fissure syndrome, second nerve is usually spared. 3-4 trigeminal nerve will be involved, whereas in the cavernous sinus 3-4-6 will be involved. 2 and trigeminal nerve will not be involved. This is how we localize the orbital apex, superior orbital syndrome, and the cavernous sinus syndrome. So the learning points will be causes of orbital apex disorders, structures usually affected, and how to localize it. Thank you.
How did the patient do?
So the patient, our patient had orbital apex syndrome with optic nerve 3, 4, 5, 6, and 7 because of the intracranial extension. We did debridement. After that, he didn't have any improvement in the deficit. We are giving him liposomal amphotericin B. He didn't have any further worsening. So if you have further worsening, enucleation or accentration as planned for it.
He's still in the ward?
He's still in the ward.
Okay, any questions? Any questions from the audience? Ask something. No one? Okay, let's then move on to the next case.